afternoon, everyone. Today, we are here live with an expert session to predictable endodontics, in which we are talking about the novel protocols of endodontics. I am Dr. Dilawar Sultan. I have done my fellowship, FCPS, in operative dentistry, and I'm working in Akhtar Medical and Dental College as an assistant professor. The protocols for the contemporary endodontics has led us to make our endodontics more predictable with some novel techniques, new steps. In this presentation today, we'll talk about the rationale for the treatment, the access opening and refinements, the glide path, the working length and patency, and lastly, but not the least, the cleaning and nipping. So, talking about the rationale for the treatment, we shall define the term rationale, which means the fundamental reasons or the logical basis. Before defining the term endodontics is a combination of two words, the endo and dont. The endo mean inside and don't mean teeth, so it's inside of the teeth. Rationale of endodontic therapy is based on a belief that a natural tooth functions more efficiently and comfortably than a bridge, than a removable partial denture, and the metal implants. I would request you guys, if you have any question answer, you can drop it in the comment box, and then we can reply them in our question answer sessions numerically. So the rationale, let's begin with the rationale. When and why we do the endodontic treatment? I ask you guys when and why we do the endodontic treatment. Definitely, when the health of the pulp is compromised or necrosed. As you all know, under the normal circumstances, the pulpodentinal complex is sterile and is isolated from the oral cavity by overlying enamel and cementum. With the integrity of this natural layer is breached, when there comes some break in the integrity of these layers, the pulpodentinal complex is exposed to oral microbiota, and then the challenge, the microorganism present in the caries lesion, in saliva bathing, the exposed area, or in dental plaque that exposed on these plaque associated surfaces. So bacteria are the major microorganisms implicated in the pathogenesis of endodontic disease. In advanced stages of the disease, bacterial organization resembling biofilm can be adhered to the canal walls. Although the chemical and the physical factors can induce the periradicular inflammation, but a large body of the scientific evidence indicates the endodontic infection is essential for the progression and perpetuation of different forms of pulpal and periradicular diseases. So let's come into the causes. As you can see in this picture, there is a deep caries lesion, and the health of the status is definitely being compromised by the bacterial load, this cavity. So this is the cause. Definitely we're going to clean this cavity. There are different school of thoughts for the caries removal. Some talk about the partial removal, some says the complete removal, and some says just seal it, like the Hall's technique. But the new concept is move all the caries part, and in such cavities, then the opening will be the bacterial contamination. So we definitely have to go for root canal. When the patient presents with the caries exposures and the radiograph seems like this, while the patient is asymptomatic, you can see the pulp horn is involved. That can be asymptomatic irreversible pulpitis, and that can be irreversible pulpitis if the patient presents in the pain. Poor oral hygiene is a major cause, as the bacterial load is too much in such a patient. And if there is a caries and the exposure occurs, that will be the bacterial exposure. That will be definitely leading the root canal. What do you guys suggest? In such poor oral hygiene, we have to go for the root canal, or we have to reinforce the oral hygiene measures like rubber brushing, flossing, and oral hygiene measures. We'll talk about this in the question and answer sessions. The repetitive dental treatments, every time you're going for the dental treatment, you are insulting the pulp, either by the physical means, by the burrs, by the chemicals, or anything you're touching with your burrs or in the acids. So you are putting your pulp to the more harm for the future endodontics. Here is a case of a trauma. IADT, the International Association of Dental Traumatology, have given their various guidelines for concussion subluxation. This typical case is of intrusive fixation. In this intrusive fixation, there are different school of thoughts for the management. Since the apical plexus of Rexall are damaged and the blood supply is interrupted, so we have to go for the root canal, following by the surgical disinfection, orthodontical extrusion, and whatever we have the technique, depending upon the parameters for the trauma. Traumatic dental injuries often occurs in accident or sport-related injuries. Chipped teeth are the most common, while the avulsed are the most severest. As you see in the picture, what should be the status of the pulp? Is it vital, non-vital? What do you guys can say? If I say necrosis, then why necrosis? Notice the distance of the pulp, as in the coronal area, the enamel is thinner, the dentine is thinner, the pulp is closer, so the distance is lesser. There are more chances for the necrosis in such zones. This is a real-time model in which the patient presents to us. Here you can see there is a vital tooth. Here there is an inflammation in the pulp, but you cannot see this inflammation on your radiograph until and unless we have an abscess or granuloma formation. We can anticipate and see such lesions on the radiograph. Same goes for the interiors. This is an inflamed pulp, but we cannot diagnose this on radiographs. This is a real-time model again. Here we can see the resorption and there is a periapical abscess, and how you see them on the radiograph. Remember one thing, we cannot anticipate a lesion on the radiograph when there is less than 40% of the bone loss is there, because X-ray is a two-dimensional view of a 3D object. So X-ray makes things clear when there is more loss has been occurred, and initial lesions cannot be seen. Like again, I'm showing you this is an inflamed pulp, and on the radiograph it's clear. You cannot anticipate there is an inflammation or not. What about OPG? Do you guys steps in for OPG for every patient? And I've seen a lot of practitioners who have gambled their patients for an OPG before the endodontic work. What is the difference between the OPG, orthopentomograph, and a periapical radiograph? We usually prefer the periapical radiograph of the endodontics because of spatial resolution difference in the both. And the OPG just give us an overall view of the dentition, overall health status of the patient, overall affected teeth, and the whole status together. So we have not been relying on the OPGs. We always try to prefer to take the periapical X-rays before proceeding to any work. But this just give us a basic view of the previous dental history, like the patient I've been visiting, what kind of a dentist and what he has been working for. Like in this OPG, I can see few bridges, few amalgam fillings, large amalgam fillings, short obturations, and some various perforation as well. So we can anticipate and plan, overplan accordingly to the stages. This gives the general view, and then when towards the periapical will give us the specific view that what we have to do with for the teeth. Now, understand the concept of the disease flow, how the disease spreads. We are talking about the endodontic disease. So the endodontic disease usually spread from the coronal to the apical area. In this very picture, you can see the anticipated incipient lesion. It can be remineralized if we work in such a lesions, and they can be mineralized without filling by taking the PTPM protocols, the prophylaxis, improving the hygiene, improving the salivary flow, improving the saturation of salivary components. We can reverse such lesions, but still, if we don't, then there will be a definitive cavity here. What about now? What about this cavity? This cavity should be filled. We cannot now demineralize it. And if still we don't fill it, then the pulp starts regressing as the process of the inflammation. The protective mechanism of the pulp will goes into regression and the pulp start regressing. If still we don't treat it, then the cavity becomes bigger, the surface area gets raised, the more number of tubules get exposed, but still it depends on the health status of the pulp. If the health of the pulp is okay and the vitality is good, we can still use the bioactive materials like pulp capping, indirect or direct, whatever it is. But if the health of the pulp is compromised, then we definitely have to go for the root canal. And if still we don't follow the protocols, then the patient will call for YEL. The pulp is in state of danger. It lost its collateral circulation and there is not enough volume for the pulp to expand. So the patient call for the YEL. And if still you just give them an antibiotic and a painkiller, then the lesion starts spreading in the apical areas. So the spread is from the coronal to apical. The lesions start developing. Still, we have a chance. The pulp gets necrosed and the periapical area is inflamed or infected. We'll still go for the root canal and we can clean it. And if we still don't do it, the lesion becomes larger, leading to a granuloma through all the portals like accessory canals, apically foraminas, apical zentais, and so forth is spread for the cavities. If still it's not been treated, then we definitely have to extract it, and it's from coronal to apical. I hope you understand the concept of the disease flow, how it spreads from the coronal to apical area, starting from the incipient lesion to the definitive lesion until the pulp gets harmed to an irreversible level, and then to the periapical area. So, what is the success of an endodontic treatment? Who we call a success? Usually painless patients call a success. I'm repeating, you can drop your questions in the comment box and we can answer them later once we're done with the presentation. The success of endodontic treatment can be analyzed clinically, radiographically, and histologically. Clinically, if there is no pain, if there is no sinus crack, the patient is functioning all well, that is the clinical success. Radiographically, when the laminar area is intact, PDL is in good form, and there is no lesion, and if there was a lesion that starts regressing, it also comes in the success. Histologically, you have to extract the teeth before designing either it's failure or successful. So I have a question. Can the root canal system be completely clean? I hope you all can hear me very well. Can a root canal system be completely cleaned? This is my question. Of course, yes, in my opinion. Talking about the evidence-based endodontics, and an article from Journal of Endodontics, we can say this tooth was treated inside the patient mouth. You can see there's a periapical lesions on the central incisor. This was treated, opened, and cleaned, not obturated. It was cleaned and then extracted from the patient mouth. After extraction, you can see the external root surface. The dentinal tubules are open. There is no mycobacteria in here. It's all clean. Going to a higher magnification, showing as the tubules in a higher level. It's all clean. There is no bacteria. Now going toward the internal surface. This is showing as the internal surface, the collagen mesh, the peritubular dentine, the intertubular dentine, all well for the sealer to get flow and form a hermetic seal. The hermetic seal is basically a 3D seal, that is a coronal seal, the apical seal, and the lateral seal. The lateral seal will form once the sealer will penetrate in these tubules. So it confirms the complete healing of such teeth. This is a case which was diagnosed with a chronic apical periodontitis and was treated by one of the admins of Academy of Restorative and Cosmetic Dentistry. And on the frequent follow-ups, you can see there's good healing over there. Always don't follow the apex. Though this is beyond the topic, the minor apical constriction and the major apical constriction, but since it's important, every fill till the apex is not the right fill. Sometimes we are crossing the fingers, it seems like similar, and we go in the other direction, it's been out of the canal, the Gatapaka. There's another case, you can see the large periapical lesion, and the recent follow-ups of 3 to 6 months, the lesion is gone and the case is healed. What do you think about this central incisal obturation? It seems well obturated, well prepared, but still we can see a lesion over here. What do you guys anticipate? Is it right fill? I'll make my comment here, but just don't believe on the mechanical preparation. We also need chemicals to clean the cavity. So the root canal is not just the mechanical preparation, it's the chemomechanical preparation. Once you remove the Gatapaka, you can see all noise Gatapaka. It's not well sealed. There was a leaking restoration, and a lot of microbiotas definitely will be present. Now, see the proper work, and the lesion get heals. So everything that looks beautiful is not always beautiful. Sometimes we have to take from the other perspectives and have to see what's going to happen. So white fill is not the right fill. We have to chemically clean the canals, and then we have to look for the healing. So healing is coming, success is coming. If healing is not coming, success ain't. Again, talking about the serity graph, there's a well condensed Gatapaka, full length achieved. Maybe the minor apical constriction is achieved. There's an endopost in the film. We don't prefer endopost. Again, that is beyond the scope of this lecture. Will come up sometime, inshallah, to talk about why not. This fill shows the right fill in the serity graph. But again, remember, we've got the two axes, X and Y. The Z is missing. And the Z will be confirmed by a 3D CBCT. But when we take an angulated data graph, you can see the miracles of a master, what a master did in here. There is no hermetic seal. The Gatapurgas are whining and whining inside the canals. There is no proper sealer flow, and this case needs to be retreated. Things look beautiful when you see from one aspect, but they look odd when you went to another aspect. So always take shifts. My point of sharing this X-ray was to take shifts before planning your cases. They're looking smart here, well obturated, but when you take a shift, it looks ugly. So definitely, most of the dentists will pull off the sleeve. But being a specialist in my field, I would definitely have to love for the root canal. The endodontics. Remember my words. Root canal is not just a mechanical preparation; it's the chemomechanical preparation. First, we have to open it, and then we have to use a combination of irrigants. These irrigants combinations are still not here, and we'll talk about in some next lecture. I hope you understand the rationale. Thank you very much. Have a good time.
For sure. Confident. आया है. Assalamu alaikum and good evening. Is the nicest explanation for the rationale explained by Dr. Dilawar Sultan. And moving forward towards the formal treatment method. So here's the topic is about making things predictable, which are already unpredictable. And why it is that so? Because nature is not a straight line. Yes, 80 to 90% of the times, the cases, the patterns repeat themselves. But what about those 8 to 10% of the times when there are a lot of variations in the root canal anatomy? So let's start off with the access opening and refinement. I know everybody of you is well aware of the access opening protocol. So my focus is going to be towards the refinement, and after that we will move towards the working length and patency and what is the most recommended and foolproof method for that, and the glide path management, which is oftentimes overlooked, and I have to re-emphasize on that. And then finally, we will discuss the concept and strategies for the cleaning and shaping procedure. So prerequisites are that you know that the tooth in its environment is in well 3D, and just one single radiograph is a two-dimensional image for that three-dimensional object. So what we need at least 2 to 3 well-angulated radiographs in order to have it visualize in your mind that what is its 3D position inside the oral cavity. And this applies more importantly into the maxillary teeth, because of the overlying structures and overlappings. We sometimes are unable to visualize what is the anatomy like. So no doubt you need to have at least 2 x-rays, one from mesial or distal shift, and one is from the straight on view. In this radiograph, you can sketch within your mind that what could be the anatomy looks like. So it makes easier for you to start off your training and cleaning procedure and your access opening. In cases of coronal restoration, such as complete crowns, PFM, so it's hard to visualize the condition of the pulp. Is it receded or in other conditions? So it is wise that you should always disassemble this crown before you proceed towards the access opening. So the most important thing is the determination of the inclination, because the iatrogenic events which occur due to related to the access opening is because of unawareness of the 3D position of the tooth. Is it straight or is it slightly tilted? So when we follow we access through the center of the tooth and we are not following the long axis, so we can end up in compromising the walls, perforations, and communications can also occur. So we have to reorient our instrument according to its long axis. And then if we try our axis, it is always going to end up in the right place. This situation is especially addressed in teeth which are having a bridge situation, because to make there is uneven tooth preparation, which leads to that we are unaware of what is the long axis. So it is important that you determine your long axis of the tooth with the help of radiograph, or you can determine by disassembling the crown, so you can have the nice idea that how much tooth structure is that, and then reorienting the burr to its long axis in order to achieve a good axis. There are a number of tools, and this is highly subjective that everybody is using their own set of instruments. But here I have some logical reasons for doing that. Most of the rest preparations can be done with simple round and tapered Fisher burr. But I would like to introduce this transmetal burr, which is oftentimes being used for cutting crowns and removing amalgam restoration. But trust me, this burr is excellent in gaining access, because our aim during access opening is not to protect the pulp, but rather we are going to eliminate the pulp. So it's wise that you use a sharpest burr, which should cut like a butter, so it's easier for you to gain nice access. So gaining access, it's easier if you follow the outline pattern and dig deep in, following the long axis of the tooth. After doing that, once you have completely removed, there is a part of refinement, because during when you are using the round burrs during the axis opening, we are creating a lot of irregularities inside the pulp chamber. So we have to make sure that during this procedure, we have to control our speed and angulation. But we have a liberty when we are in the safe zone, especially in the cornal area. Speed can be whatever you want, whatever angulation you want. But when you are in the caution zone, whatever speed you have, but your angulation must be strict, must be parallel with the long axis of the tooth. But when you are in danger zone, it is highly recommended that you should control the speed as well as the angulation of your handpiece. Transmetal burrs, if they can prepare, they can slice through the PFM metal crown easily. They can easily go through the amalgam restorations and through the natural crowns. And especially this burr is effective when the patient is presented to you with irreversible symptoms, when the anesthesia is not effective and there is a slight need of intrapulpal injection. So this burr is quite effective for that reason. Diamond is not even close to its preparation. So again, control as you go deeper to the pulp chamber. For axis refinement, I recommend to use the Endo Z burr, and it has a safe handle tip. So if accidentally you touch the floor of the pulp chamber, there is no harm. And the objective here is to create a funnel-shaped cavity so that you have easier access in all canal systems. The next step which comes is not pulpectomy, is not removing the pulp, but scouting the systems, that how many canals a tooth may have. And starting off with number 10K file, we just have to estimate what could be the canal size. Is it, if the number 10K file is binding inside the canal, it means that the canal is quite narrow. If number 15 is quite loose, that it means that canal is large. So we also have to determine if there are any calcifications in the pulp chamber, or if the handle of the file is tilted, deflected by the dentinal shelf. Do we need any straight line access? And then the root canal system anatomy, the knowledge of root canal system anatomy is important in order to achieve a reproducible glide path, and we will see that. So after axis opening, fill the chamber with sodium hypochlorite. And our aim is not to do the pulpectomy, but just to explore the system. Our objective is that, is there any resistance when we are inserting the file inside the canal? And if you feel any resistance, you just pull back and try. And usually 4 to 5 cycles are required to reach to the apex. But in cases of calcifications, if you can just made up to middle third, I think it's a good idea that rather than you proceed any further, you should secure that portion first and then proceed further. We will discuss that in the following slides. So during the scouting section, you must have noticed that the handle position is rather tilted. So we have to create our straight line axis because the file has exaggerated curve. And this dentine shelf is binding the rotary file and putting a lot of pressure, which can eventually cause rotary fatigue. So the objective here is to eliminate this dentine shelf. And how we are going to do that? We can use any orifice opener from any manufacturer. My favorite is SX. So what I'm doing, I'm just shaving out, I'm just smoothing the dentine shelf. I'm just applying the pressure on the opposing wall, which is away from the furcation. And in this way, I can eliminate this dentine triangle, and I can create my straight line axis. Another way is the axis refinement using ultrasonics. If you have some calcifications in the pulp chamber, it is easily eliminated with the help of ultrasonics. The modern ultrasonics, which are piezo, they have linear oscillation. So they are quite helpful. You don't have to apply force, just hold it like a brush and let the tip work. If you apply a lot of force, there will be no vibration in the tip, and there will be no sandblasting action, and there will be no cutting. So if you want to use ultrasonics, use it just a feather touch. Okay. So in this way, you are providing the space for sandblasting action and removing precisely the dentine. You can use both of these things in combination. This is one of the cases in which the patient presented with food picking in the crown, and upon cleaning up, I can see that the problems I can face during the cleaning and shaping procedure. But first of all, I cannot clean this area with the help of burr or triple strange or a prophy paste. I need something energetic and gentle at the same time, and that is fulfilled by the ultrasonics. So ultrasonics help me retrieve file, help me clean up, help me clean up the debris, and help me shape up the canal. So it's a most versatile system. So I would encourage you to shift on towards the ultrasonics. So notice now that what is the position of the handle. It is now straighter, and now can be easily facilitated inside the canal. The next part comes with the working length and patency. You all know that what is working length, and it determines that how far we are in any canal system. And this directly affects your overall treatment quality, because it affects the degree of pain. If you are short of the working length, you are leaving a lot of remnants back, so it can reinfect the system. You are not removing the whole cause, as Dr. Dilawar has explained already. And if you have done over preparation, there is another. So if you place within the correct limits, it has the potential for determining the successful treatment. If you don't, there is a chance of over-instrumentation or under-instrumentation. In both of the scenarios, there is the failure. So what is the best method for working length? So is it X-ray, or is it the apex locator and the X-ray method? Let me give you the example. In the left side of the X-ray, you can appreciate that I tried to calculate the working length as on the basis of tactile feedback. 40% of the times in the mesiobuccal cut, there is a palatal curvature, and we don't see that in straight on X-rays. And we always, what we see that it's a short root, but the opposite is true. So this was the visual result of the situation. Okay, the palatal is fine, mesial is maybe slightly over, and distal is perfectly over. But this is not the scenario. When you recalibrate your working length, which you actually felt on the basis of your tactile feedback, with the help of apex locator, it was short. And this is quite a common problem in maxillary teeth, and especially in maxillary molars and second molars. So you have to rely on the apex locator, because the mode of action of apex locator is rather different. So my recommendation is the apex locator. So let's see that where our obturation ideally must end. So this is a classic illustration in which we can see the anatomic or the radiographic apex here. And there is a significant distance between the radiographic apex and the actual apical foramen, and which can be thought of, it's between 0.3 to 6 millimeters. Our objective is to eliminate our endodontic preparation and our filling at the physiologic terminus, and this is the place over here. And this is the apical constriction. and we call it as cemento-dentinal junction or the minor apical foramen. And this distance from the radiographic apex to the physiologic terminus is almost between 0.5 to 1 millimeter. So let's see in this animation that what is this all about. The working length and patency, they go hand in hand, and we have to establish that what is the patency, that we have to establish that our file is going through the apex. Okay, so this is how we establish that. In the previous illustration, you have seen that how we are going to perform the working length to the apical area. In this video demonstration by Dr. Clifford, we can see that we have a separate radiographic apex and we have a different physiologic terminus. And to this physiologic terminus, we have our radiographic terminus where we should terminate our working length. And once your file is in this position, and you can only measure it with the help of apex locator, not with the radiographs. Okay, because we cannot discriminate with the help of, yes, we can see that, yes, it's in the right path. And once you have established the working length, push the file through the apex intentionally, deliberately, and repeatedly to make sure this pathway is open. Don't worry, there is no significant biologically harmful outcome. So this is how we determine our working length and patency at the same time. So what is the most recommended method? It is the combination of apex locator or the X-ray method. So moving on towards the cleaning and shaping part, and we have already done estimated size of the canal, if there is any calcification, and we have established our straight line axis. Now this is the part for establishing the glide path. But before we move towards that, we must visualize the anatomical interferences with the instrumentation. And for that, we have to understand the canal configuration determined by virtuity. Because this tells us that how much irregularities a canal may have in the middle or in the apical section, which can eventually interfere with the glide path. This is an excellent illustration in the 3D cleaning project, and I can bet on it that this is we tend to feel on everyday basis of the cases, and we all do that. Just we don't comprehend. And today I'm going to give you the visual analogy. So let's suppose in this animation you have a single canal, and if it is joined, it's just one canal, it is exiting, it is making two portals of exit, it's two canals. So if you just add one of the portion or portion of the dentine in the middle, it makes two canals, and which are joining in the middle. If this area gets deeper, still the two canals which are joining in the middle third. This part of the dentine sometimes makes that which canal is bigger, which canal is smaller. And if we have some obstructions in the middle third, for example, if we add this little part here, the movement is telling us whether it's virtues 4, 5, 6, whatever classification. So what is the problem here going on, and what could be happening over there? Oftentimes, if you have noticed that during the instrumentation, you can take all the way your instruments to the working length, but it's not reproducible. There is something which is sticking when you are trying to insert to the apex, and this is the these are the apical irregularities. And to eliminate that, you pre-curve your number 15 file and then try to bypass that portion in that regard. So these irregularities are always there. You just have to find it. So oftentimes, because we don't know what is the ideal finished part and what is the anatomy, we have to produce a smooth glide path which is unobstructed, and it must be reproducible. And what does it mean? Let me explain. This illustration is also done by Dr. Clifford, and it beautifully explains that once you have entered inside the canal orifice, it's just like that you are on the roller coaster, or you are skating on an ice slide, or you are on a water slide. Just think of it. If a single obstruction you experience before you, what will happen? Yes. So we have to make sure that there is no obstruction from the canal orifice all the way to the apical portal of exit. So this is the glide path. So how to do that? You create your straight line axis, you use your number 10K file, and you insert inside the canal and try to carry all the way to the working length. Since you have already established the working length with the help of apex locator and radiographs, now it's time to establish and confirm the patency that yes, this area is completely open, it's not blocked by debris. And then smaller strokes, 1 millimeter and all the way, 2 millimeters and then all the way, 3 millimeters and then all the way. So it tells you that you have a reproducible pathway all the way to the apex. And now you can carry on your any mechanical or rotary instruments. But before moving forward, we must have some objectives in order to perform a cleaning and shaping procedure. And these objectives, still not changed, were described by Dr. Herb Schilder in 1970s. So in summary, what it says that we must have a continuously tapered preparation. We have to maintain the original anatomy. We have to maintain the position of the foramen, and we have to keep the foramen as small as practically possible. And if we are doing it haphazardly, we can face some of the complications we will see in the future. So in this case, which I have done, my objective is that the taper must be continuous. I have to maintain the anatomy in this double S curve. So on the working length, I can see that this is the portion of position of my apical foramen, and this is number 15K file. So I have to keep the foramen as small as practically possible. So after complete treatment, I have fulfilled all of my objectives. It is continuously tapered. It is following the anatomy. The position didn't change, and I didn't enlarge the foramen as much. So if I do everything haphazardly, so there are failures and needless complications. For example, the first thing we experience is the canal blockage, because if we are not simultaneously cleaning during the filing action, the debris which is generated is getting right inside the canal. So we have to frequently do our preparation. And ledge formation. And what are the reasons? Perforations. What are the reasons? Instrument failure. What are the reasons? Reasons can be if you are working short and you are just packing your debris inside. You will never able to achieve a full working length. And in an attempt to prepare the apical third first has a great drawback, because the dentine is engaged a lot by the file system. So it means that it is generating a lot of debris. That debris is right going inside the same canal and packing in. So it's important that you start to clean up from the coronal, then middle, and then finally prepare the apical third. Larger and stiffer instrumentation and the method of use, if you are using aggressively out of frustration, you will end up with something wrong. So how to achieve these objectives? There must be some concept and there must be some strategy for this cleaning and shaping procedure. It's simple. The cleaning and shaping procedure can be simplified if we just break the whole procedure in a series of small steps. It's quite easy. And how to do that? Divide the root into the coronal, middle, and apical sections. Or in the more contemporary way, you just combine the coronal and middle and call it a body section and leave the apical part. So first prepare the coronal, then prepare the middle, and then the apex. Or in other words, prepare the body first and followed by the apex in the end. The strategy is, we know that the average length of the tooth is falling between 19 to 25 millimeters. and the average length of the crown is between 10 millimeters. So it's giving us between 9 to 15 millimeters of the portion of this root. And if we just divide this portion into coronal, middle, and apical portions, we get 3 to 5 millimeters in the coronal portion, 3 to 5 millimeters in the middle portion, and 3 to 5 millimeters in the apical portion. And making and breaking in the sequence makes us easier to prepare the canal in more predictable way. So what should be the preparation sequence? We have to scout until the coronal and middle third. Don't go to the apex. No, not now. We have to pre-enlarge the pulp chamber and the coronal in the middle area first. And then we have to prepare the coronal and middle first, followed by scouting, means just to make sure if there is any variation in the anatomy, because most of the variations occur in the apical third. And after making sure that there is nothing and establishing the glide path, we can finish the apical third. So since we have already performed some of the access refinement in the beginning of this stage, there are some advantages of pre-enlargement, and which are gives us better tactile control. Means in the beginning, the file was binding a lot of dentine during the course of its apex. So when you pre-enlarge, your file is mostly binding in the apical third portion, so you have a tactile feedback. Number two, it holds more irrigant, means more disinfection, more dissolution of the tissue, means more debris removal. And during the pre-enlargement, bulk of the pulp and necrotic debris is removed, so therefore the patient is more comfortable. So there are a variety of advantages of pre-enlargement. So once you have pre-enlarged your canal and you have established the glide path, now it is time to enlarge the glide path. To how much extent we have to increase the apical portion, and we have to expand. And for this reason, we can use rotary glide path files, and they are excellent these days. So I'm going to give you the concept of the apical enlargement with the help of determining with first apical binding file. And what is the first apical binding file? It is simple. The file which binds all the way to the apex passively is your first apical binding file. Let's say you had number 10 K file bound all the way to the apex. And research says that if we just increase 3 to 5 numbers, or we just increase 3 to 5 steps of this apical diameter, there is no statistical, there is no significant difference between these 3 steps or 5 steps. So having said that, we will perform a 3-step increase in the first apical binding file. So let's suppose we have number 10 K file in the beginning. So we can increase up to 15, 1, 20, 2, and 25. So our final apical preparation will be ended on 25K. So we have increased up to 3 numbers. So there are a variety of apical preparation files in the market. F2 from ProTaper, R25 from Reciproc, 0425 iWays, 0625 One Curve, 0825. A variety of systems are offering a different. So you must have all these tapers available, because there is a chance of narrow canals, extreme curvature. You cannot carry an 8% instrument into an abrupt curvature area. So let me explain with this side that what is the importance of all of these steps. This is an experiment in which I want to tell you the importance. The efficacy of irrigation is not only dependent on the concentration or the duration, how long you use it, or the volume, how much volume you use it, or what was the activation method you use, but also the penetration of the needle is also important. And out of all, the establishment of apical patency is also very important. So in this model, this distal route was prepared following all protocols such as irrigation after successive instrumentation, intracanal heating of the sodium hypochlorite, and intracanal vacuuming, ultrasonics, and this cycle was repeated after every instrument use. But in the mesial system, everything was performed except patency. I didn't perform patency in the mesial system, and you can appreciate by looking at the apical portion that there are distinct two portals of exits. So what I didn't do here, I irrigated after each successive instrument. I performed intracanal heating, I performed ultrasonic, but I did not perform patency after every instrument. Remember, with the help of patency, we confirm that this apical portion is clear open. Okay, so uh, during this session, the use of standard 24 gauge needles and 30 gauge double sideband needles, you can appreciate the depth of penetration after just use of orifice openers. So this is the maximum depth of penetration. And after preparing the canal, I have to activate the solution with the help of the system B, and then intracanal activation, and after that cleaning with the ultrasonics, and then vacuuming from the canal. So this is the common protocol that how we should employ. So we are not leaving any debris inside, and we have to establish the patency that yes, all of the debris has been picked. There is nothing left in the apical zone. So after preparation of the middle third, this is the limit for the penetration of a 24 gauge needle. Beyond that, it cannot go any further. And research says that the maximum depth of penetration of irrigation solution is no more than 1 millimeter beyond the tip. So if this is the region, your irrigation can only penetrate up till here, not more than that. So what about this area? This area was only instrumented, but not disinfected with the help of irrigation activation. So it is always advisable that you use a 31 gauge needle, and especially the double sideband. Okay, you can appreciate in this region that these are the sideband needles. And you can also appreciate that the file reaches all the way to the apex and made sure that this area is completely clean. But what happens when I obturated that? You can see that the distal system is completely packed, and there is the lateral in this extracted tooth, which was also filled. But in the mesial system, I can appreciate that the isthmus was filled, but just because I didn't establish the patency, this was the problem, that I couldn't fill that area out, because I cannot make sure that if this area is free of debris or not. So the debris is packed inside, is not allowing your filling material, your gutta perca, to go inside. Not even the sealer can penetrate in this area. Some of the cases, this is the initial case I discussed with that after access opening and the working length determination. And after following all of these protocols, you get a nice post-operative X-ray. Another case in which the caries exposure pulp stones with the help of ultrasonics, you can gain excellent access opening, and this is the extremely curved canal, and you have to increase to a certain level in order to clear the pathway. So pre-enlargement, and this is the same protocol again. It is repeated here. This case has already been shared on ARCD group. You guys are welcome to follow the protocols on these cases. And this is another case in which you can see a nice looking chamber, and after it is well facilitated that you can restore with the help of a fiber post. Another case which is posted on Facebook, it is a 29 millimeter tooth, and we face problems, and the precautions during cleaning and shaping you can follow on the very case which is posted on the group. So that's it for today. I hope you must have some visualizations what is going on inside the root canal system. So moving towards the question and answer session. our question answer session. Live question answer sessions. ये written में है. How can I avoid transportation in curved routes?
Avoid using stiffer instruments because the stiffer instruments tend to straighten them when they are inside the adequate portion. So you should use the heat treated files with some without the treatment rules, such as IPM and heat treated files are excellent in terms of avoiding transportation.
And plus, you have to pre-curve your manual file. Lay the curve radiographically and then pre-curve your file in the apical portion so that you can not straight your canal system.
Bioactive type of root canal sealers I prefer the most, especially bioceramic types. And secondly, you can see that I can use resin-based sealers. They're also good in terms of radiopacity.
For your question, Isha Malik, curved canal with simple hand files, you are supposed to use anti-curvature filing technique. Recurve your file, show a lot of patience while doing filing because these curves will not spare you if you take the bigger files in the canal and start to filling them. Achieve your apical potency and then go stepwise.
Just for the experimental purpose, I did not maintain the tendencies. I just wanted to show you guys that what happens when we don't establish the tendency. So doing irrigation, activation, intracanal heating, 17% EPD, intracanal vacuuming, everything is making sure that you have eliminated all the debris. But just one thing, which is patency, that if you cannot feel that you have pushed through the apex, you cannot make sure that the patency is established and that area is 100% clean.
Any other questions from your side? I hope you understand the lecture.
If we don't have an electronic irrigation system or ultrasonic device, how do we make sure our irrigation has reached the
Use small needles, just 27 gauge needles, 30 gauge needles, side vented. You should always be 2 to 3 mm short of your working length with your irrigation needles. And don't use a lot of pressure while irrigating.
Use smaller gauge needles. Smaller gauge, 31 gauge, 27 gauge needles are ideal. And not the 24 gauge needles. Activation is another. With the help of activation, you can make sure that your laterals, your clear layer, everything is clean. But with the help of patency, that small 0.5 to 1 millimeter area, we have to make sure that yes, this is also clean.
And if you don't have an electronic irrigation device, you can use your M4 handpiece with a spreader in it. And then after irrigating your canal, you can use the spreader in the canal to activate your irrigation material, like hypo, EDT, or whatever it is.
It's a simple.
And please, don't talk about the apex. In root canal, we are supposed to talk about the minor apical constriction because the apex is usually the major apical constriction, that is the outermost junction for the root.
We are talking about the physiologic terminus where ideally our observation must end. And for contemporary endodontics, I think we have to upgrade ourselves towards these instruments. You can buy even any ultrasonic device. You can buy any ultrasonic device, and you can have ultrasonic attachments.
Usman Ashraf, you have to choose your sealer according to your availability. What kind of sealer you use? Ideally, we prefer bioactive based sealers like MTA based sealers. And for the flow, some people prefer resin based sealers and some talk about the sealer packs. So it's totally dependent upon you. What kind of sealer you prefer in your practice?
You can say that our obturation must end 0.5 to 1 millimeter from the radiographic apex, but it doesn't mean that we are not supposed to instrument that area. will make you sure that yes, this area is properly instrumented. And passing through number 10K file is causing no biologically harmful effect. You are also playing with your goods. You are also performing deep margin. You are also performing cauterization of the soft tissues. So just with the help of pushing beyond this apex, it doesn't cause any harmful biological effects.
And maybe your canal obstruction is in the middle and in the coronal portion, so that your patency is not achieved and the gutta perca get bends when you're pushing it in the canal.
No, not at all. Sodium hypochlorite and hydrogen peroxide. No, not recommended.
Hydrogen peroxide is not indicated as a litigation material because it produces nascent oxygen and that can lead to emphysema as well. So sodium hypochlorite is the ideal gold standard irrigant.
The sequence of irrigation is simple. That you are using your ultrasonic, which is connected with your distilled water. Okay, so start off with the sodium hypochlorite. Once you are done with sodium hypochlorite, shift towards the ultrasonic. Make sure that all of the sodium hypochlorite is gone. Now shift to 17% aqueous solution of EDTA solution, moving back towards the ultrasonic again, so making sure that everything is clean. And then using the intracanal suction, using any irrigation needle, just vacuum, making sure that nothing is left inside.
And please don't use the combination of sodium hypochlorite and EDTA because that can lead to the formation of the brown precipitates known as perachloroanilines. So always use saline or distilled water in the middle before jumping to another. And remember, sodium hypochlorite is based upon free chlorine, and the active time is 2 minutes. So after every 2 minutes, you have to replenish your solution.
And the amount of time required for a complete root canal is that you have to expose a certain portion of the canal, at least for 30 seconds, on a concentration of 3% sodium hypochlorite. If you are increasing the concentration and if you are increasing the temperature, the contact time decreases proportionally.
And in short, you can say if you are doing a molar root canal, so you can prepare your system in 15 minutes and the next 45 minutes play with the irrigants. If you want the proper cleansing, proper hermetic seal to be formed, you want all the system to be cleaned, use a lot of irrigants, but not with pressure, not a lot of amount, so that the patient gags and vomits. So use it in very small drops amounts. Don't make it flood with your irrigants.
You're most welcome, Dr. Kunal.
Anything else you guys have to say?
Okay, it was
nice to see you guys. It was a good question answer session. I hope you learned a lot of things because the questions were less. So I hope you understand things in a much better how.
Join ARCD and motivate others to do the same.
And ARCD's Academy of Restorative and Cosmetic Dentistry, in which there are 5 multi-potential dentists who are working with the special domains of root canals and aesthetic procedures. Thank you, Malia.
Thank you so much, everyone, for your time. I hope you had a nice understanding of most of the concepts in a single tooth. Could you please elaborate that? Yes, it was a molar tooth, and both of the lingual and the buccal walls were less than 2 millimeters. And since it's an endodontic teeth, if you have the walls less than 2 millimeters, either you have to do custal coverage, and you have to provide at least fiber posts for extra reinforcement because the patient was 19 or 20 years of age. And I wanted to last this tooth as long as possible. So this increases the clinical outcome and the longevity of the restoration.
You're welcome, Ubi. Usman, there is no relative point to talk about a single fiber post or 2. We can make even 3 in every canal because the purpose of the fiber post is to reinforce the core. So if the core is weaker, despite of filling the canal with gutta perca and the chamber with the gutta percha we usually fill, we can place the fiber post. Because the fiber post is not damaging, and we are not supposed to place the fiber post in the coronal, middle, and apical third. There is no mandation for the length of the fiber post.
For the length of the fiber post, the simple rule. You have to be 33% inside of the root canal, as if you calculate the total length of the tooth, and 33%, this is the length of.
Like for the metal post, it's 2/3 of the canal, but for the fiber post, it's not 2/3. It may be 1/2, and maybe less than half. So because it's bonded in the canal, it's just reinforcing your core. It's not reinforcing the root canal system. So with gutta percha, you cannot have a good seal. So ideally, you are supposed to use fiber post in broken teeth, despite of the metal post. That can lead to the vertical root fractures and other complications.
Thank you everyone for watching this.
Thank you.
Stay home.
Stay corona free.